Good evening, friends. It's a pleasure to see you all this evening on yet another important edition of the IGS Prime. A warm welcome to IGS fraternity, senior members, and the entire surgical fraternity who are watching from India and out of India as well. Ladies and gentlemen, IGS Prime Time showcases the best of the talents across the globe and in the country, and it takes turn to dive through all the subspecialties so that we have a balance of taking everything one after the other. Now I have the honor of inviting our president, Dr. LP Thangavelu sir, who's a dynamic president who has taken over in a rather difficult time of the corona. We look forward for more academic endeavors, and he also is the chairman of the multiple educational group of institutions, and he's the chairman of the Ashwin hospitals, where he started laparoscopy as early as 1992 in India to start early laparoscopic surgeries, to his credit. Ladies and gentlemen, he has been trained at multiple centers in the Europe, the Keeler University, and various training centers. He has visited almost across the globe, perfecting the laparoscopic surgery skills. He has a lot of upcoming plans, and his calendar is filled up with every week in the coming few months. May I have the honor of inviting Dr. LPT sir to welcome the audience and give his presidential minutes. Over to you, sir.
Namaskar. Good evening. Good evening, friends. Good evening, Rajesh, Vivek. Good evening, Secretary. At the outset, I'd like to thank Professor Kanagavel for taking up this wonderful job and organizing this prime time for the last 1.5 years, and he has made it very popular. In our IAGS prime time has become very popular across the country, not only in the country, in various countries, the globe also. IAGS, you all know. I don't want to take much of your time. Just IAGS is a premier organization in minimal access surgery in India. So, with more than 8,500 members, and the strength of IAGS is the training of surgeons and giving fellowships in various programs. IAGS, from in my when I took over as president of IAGS, my theme of this year is minimal access surgery for all. The idea is we have to train as many surgeons as possible in our country. Especially we target the young surgeons who should be trained well in minimal access surgery, because without minimal access surgery, you all know, surgery is not complete. Only when we train a lot of surgeons, young surgeons, then only, the ultimate idea is to give this minimal access surgery to reach the poorest of the poor of this country. All the places, the remote places of our country, the person should get the benefit of this minimal access surgery. And for that, more number of surgeons should be trained. And with that vision, we have started our, fellowship programs, FIAG, fellowship in FIAGS program, and advanced fellowship programs in minimal access surgery in various topics, falls. We have trained more than 3,000 people in basic fellowship courses, and more than 1,000 in advanced laparoscopic surgery, and in endoscopy, EFIAGS, endoscopic surgery. we have trained more than 1,000 people. This year, from March 25 onwards, every week, without a break, every week we are having already, more than 13 FIAGS program have been fixed. More than seven false programs have already been fixed. And EFIAGS program, 3 programs have been already, fixed. The calendar is full. Paji also, we have confirmed on program at Tiruchirappalli. So next year, from March onwards, we are on the wheels and going place to myself and our secretary. We have to go every week to some place in some part of the country. We will not be staying in home from March 25th onwards. So this is our program. And today, we have an excellent, Kanagavel has organized an excellent program with 2 eminent speakers. One is Rajesh Sivaprakasam from, even though he lives in London, I'm very happy he's from India, that too from nearby place to my place. And he has, after long period of training and practice, he devoted himself for this wonderful cause of development of instrumentation in robotic surgery, in minimal access surgery, that he has invented recently. He was telling me on the other day. Very good, and I wish him all the success for his new inventions. And another speaker, excellent speaker, young man, Vivek Bindal, is from Max Delhi, and he is going to talk about robotic surgery, edge in hernia surgery, is that? So with these 2 talks, today is going to be a wonderful day, and we are looking forward support of all the viewers for this prime time. Already we have a huge fan follow for this program, and yet another program this is. I welcome you all for this wonderful program. Thank you, Kanagavel.
Thank you, President. We set the meeting in order. Can I have the honor of inviting Dr. Satish Mehta, the Honorary Secretary of the Indian Association of Gastrointestinal Endosurgeons, to read the citation for Dr. Rajesh. Dr. Mehta, sir, please.
Good evening, everybody. I welcome you all on behalf of IAGS. It's an honor to introduce or give a citation of Mr. Rajesh Sivaprakasam, who is a consultant transplant surgeon and has joined Bart's Health NHS Trust in 2013. He's a consultant in renal transplantation and dialysis access surgery, lead for robotic renal failure surgery and access analysis and research. His research work has been published and presented at conferences worldwide. Dr. Rajesh was also involved in the creation of world's first risk score in prediction for the outcome of following the intestinal transplantation. He is a passionate educator and lead education for Year 5 medical students from QMUL in renal failure surgery at Bart's Health NHS Trust, and has implemented a structured work experience program for students from east of London who are interested in pursuing a career in healthcare. This was recognized at the Bart Health Community Award in 2018. Dr. Rajesh is driven to educate and empower patients in managing their clinical problems, and an executive director for MedLearn, and leads many clinical and technology-based innovations to empowering patients living with chronic diseases such as kidney failure, demystifying their care. He led integration of many technology in the healthcare and is an active member of advisory boards and guides development of healthcare innovations. He leads many research projects to advance care offered and strives to enhance care offered across the globe. And today, he is going to present us about the innovations in MIS instrumentations. So welcome, Dr. Rajesh, and over to you for your presentations.
Thank you. Thank you, President and the Secretary and everyone in IAGES for this wonderful honor to share my thoughts on innovations in minimal invasive surgery instrumentation. So thank you for the kind introduction. And moving on to the next slide. I'm a transplant surgeon based in London, and as mentioned, I'm involved in educational and research roles. And I'm quite passionate about enhancing the opportunities what we offer for our students who wants to come into healthcare, our trainee doctors who wants to pursue a career in surgery. And also, I'm passionate about empowering patients to understand more about these diseases. So going on to the next slide, I'm actively involved in a lot of patient charities, and I enjoy the fact that I can be a part of the team involved in integrating innovation-based solutions into our healthcare systems. Next slide, please. And so to give you some examples of what I'm involved in, these are some of the products what I'm currently involved in. So we have got an ultrasound probe, which is a point-of-care ultrasound. We have developed a tool which is being validated at the moment where we can really do blood tests without really putting a needle in. I'm working closely with the team in US about identifying a cost-effective way of doing microscopic surgery, and also AI-based platforms for patient triage and surgical training. So therefore, I really enjoyed this element of my work, which due to COVID actually accelerated, and the adoption of is really excellent at the moment. Next slide. So with that background, when Professor Kannagubale and the President asked me to talk about the innovations in minimal invasive surgery, I wanted to think about what does that mean for me? Minimal invasive surgery for me is an alignment of technology, innovation, and surgery coming together, and to perform a surgical task to deliver a patient care in the safest way. The intent is to improve the patient care, and the standard of the procedure and the safety of the procedure has to be non-inferior to an open procedure. It has to be easily adoptable. It has to be available globally. And it has to deliver a patient-centered care. As President identified, one of the themes of IAGES, which I applaud, is the intent to make minimal invasive surgery accessible to all, not to a few. Next slide, please. So therefore, when we look at the challenges what a laparoscopic surgeon faces, I mean, we have adopted this technology over the last 3 to 4 decades, but still we have difficulty in controlling the vision. We have access to have, it's challenging to have consistent assistance, and that thereby impacts efficiency. There are limitations to the assessment of the tissues what we are handling with, such as haptics. There is no 3D images available widely. What about the shared vision? Can we share the vision with other people? So therefore, the solutions what we really need is we need to find vision systems which helps the surgeons to enhance the vision what they have. We need to think about advancing the instruments, such as articulated laparoscopic instruments, improvement on the hemostatic devices. How about looking at improvement in the surgical ergonomy? How do we measure an ergonomy? How do we make a surgeon effective in delivering the task? And also, more importantly, these are physically demanding surgical techniques and procedures. So how can we protect the surgeon's well-being in performing these procedures? And of course, as I touched upon earlier, can we make this accessible globally, and can we support each other in training? So therefore, a new surgeon who wants to start an advanced procedure doesn't have to face all the challenges alone? And finally, can we make this minimal access surgery superior to open surgery? That is the mission for us. Next slide, please. So therefore, I think looking at the improved vision per se, there are a lot of developments out there presently. The surgeon-controlled vision, the freehand robot, I will talk about it later. That is the innovation I'll be talking at length a bit later. Of course, there is already advanced tools are available for improving visualization, such as 3D imaging, the new elevation scope, which is from Medtronic, where you can assess the perfusion of the different segments of the organ, what you're looking at. And therefore, your precision of what you want to do becomes more specific. And also the assessment of the area becomes better. How about a flexible laparoscope? I haven't used it myself, but certainly I'm sure colleagues who have used it found it useful. But certainly the vision management and the way we visualize the operating area is certainly improving. And I would say that we are at a point where we have sufficient tools to enhance our vision in a laparoscopic surgery better than what we have. Next slide, please. So therefore, in this image, what we really wanted to talk about was really how you can visualize that using an elevation. And when we look at the articulated instruments, laparoscopic instruments are very physically demanding for the operating surgeon because they have restricted movements. But the articulated instruments, which are there, and certainly it is helping us to improve our efficiency. Personally, for me, I felt that it certainly needs a bit of learning curve because it is the thought of using steps, which normally I wouldn't think through in laparoscopic surgery. So therefore, certainly the FlexDex and Artis Sentinel, which we used, I had that learning curve early on, but definitely it has got a place in certain types of the procedure, what we perform. Next slide, please. And of course, there is robotic surgery. So therefore, I'm sure all of us are familiar with it by now about the robotic surgery, and it is a big cultural change in the way we perform minimal invasive surgery. There is a human-to-human contact, and then there's a robot add to it when it comes to robot-assisted surgery. It definitely needs more structured approach with a clear plan, which is shared with everyone in the operating room, because there is this very large device which can cause significant disruption or even, I would say, damage to the patient if it is not dealt with any care. And of course, there are a lot of advantages in robotic surgery, which we need to be aware of. Sometimes when we are operating, we forget the benefits of the additional benefits of the robotic surgery. So therefore, being familiar with it is important. And lastly, of course, it is important to have emergency protocol with nominated individuals and responsibilities when we deal with robotic-assisted surgery. That is certainly a bit more added to what conventionally we do in open surgery, where the team comes together and we can manage unexpected situations a lot more easily. Next slide, please. So the robot itself, we are all aware of the Da Vinci, who had complete monopoly for the last, I would say, 20 years. We are all familiar with these devices, the parts of the Da Vinci robot. And in the next slide, you could see the new robots which are coming onto the market, such as Bercier's robot, which is on the next slide, or the Hugo from the Medtronic, which is shown on the next slide. Next slide, please. And the other robotic devices which are shown in the next slide, which are available. So therefore, there are more opportunities available for us to engage in robotic surgery. Next slide, please. So the reason I think why a lot of the industry partners who wanted to get into the robotic surgery is the demand of robotic surgery. People are getting more aware of it. We are getting more experience in performing these procedures. The outcomes in certain procedures are significantly better. So therefore, there is certainly an urgency amongst all the industry leaders to invest in this robotic surgery. But next slide, please. Certainly, it is not without its challenges. When we compare between laparoscopic surgery and robot-assisted surgery, certainly robot-assisted surgery adds a 3D visualization. You have a lot more dexterity to your performance, or your operator's ability. You can scale up the motions, which at the moment in laparoscopic surgery is limited but yet available. But the biggest problems I feel, what we all face in introducing robotic surgery, is the high startup cost. It is not available for everyone. It certainly needs extra staff to operate, and the staff have to be fully familiar with the device. For the robotic surgeons amongst us, we will know that we have to put good amount of time in getting the team familiar with the robot what we have to use it safely. In many centers, particularly in my center, it is not used in emergency. It is not because of lack of willingness, it is because of lack of trained staff. And of course, the current robots, you can't transport them easily. There is a team in the US, they tried and they weren't successful. So therefore, these are the big problems which are holding us back in making robotic surgery available across the globe. Next slide, please. So what is the solution? What do we need? Really, we need a device which is patient safe, which is easy to adopt by all of them in theater, not just the operating surgeon. The staff nurse should be able to know how to use the device, how to be familiar with the safety aspects of the device. It should help to improve the efficiency of the surgeons and surgical teams. It will be great if it's portable. And of course, it makes a huge difference if it's cost effective. That is the kind of tool what we need to enhance what we offer in robotic surgery. Next slide, please. So one of the potential solutions, what I would like to propose and what I would like to show you in the next slide is really to show you the device what we want to launch in India. So the other small factor which I missed was that the president said, we need more surgeons. We need more minimal invasive surgeons. The demand on laparoscopic surgeries are going up. So therefore, there is no doubt that I think the theme what IAGAS has taken is timely that it is being pursued. And the urgency is near and now. So we have to do that. So with that, in the next slide, I would like to introduce you one potential solution, which is called freehand surgeon. I mean, it is registered as a robot. It is from UK. But when I started working with it, I realized that it is actually a collaborative robot. It is not a standalone device. So I named it as cobot instead of a robot. So what it does, there was a video there, but unfortunately, we're not going to show it at the moment because of the link issue. But nevertheless, it's really able to hold the camera for the surgeon so that the surgeon can control the camera with their head movements. And oh, amazing what the team has managed to do. So in this video, what you will see is the device, how we can use it. So it is a very simple device with 3 joints. You can connect it onto the side of the bed, wherever you want it to. And the camera is held by the robotic arm. So therefore, the purpose is a lot simpler than any complex devices which are available. And you wear a sensor in your forehead, and there's a sensor among your laparoscopic screen. So with your head movements, you give instruction to the sensor, and then you make the robotic arm move. So therefore, you are in complete control of the movement of your camera. So the visual field where you're going to look is you are fully in control of it. And the second thing is, it's a very simple thing to set up. So as you can see, you have to press the button on the sensor to switch it on your sensor in your forehead and the robotic machine itself. And that's all it takes. The machine has been set. Then you activate it and use it in the direction how you want to do it. And as you can see, the amount of angle of the vision, what you get in the peritoneal cavity is significant enough for us to perform 3 to 4 quadrant procedures with ease. And of course, the more one gets experience, they can do complex procedures as well. And This is the device which I'm delighted to announce that we will be launching it on the 17th of March in India for the first time. And I'm proud of the fact that I'm going to be part of the team where we can bring in this device, which is being used in UK and other parts of the world, and deliver it to colleagues across the country to enable them offering robotic surgery. So therefore, what it offers us, as I will talk you through in the next few minutes, is the benefits of what this device can do in surgical practice. Next slide, please. And in the when you see this, and I think as I mentioned, we are launching it on the 17th. And next slide, please. We did a project to understand how safely we can introduce this technology into our healthcare. So I chose a procedure which is low risk and high volume for renal failure patients, which is laparoscopic peritoneal dialysis catheter insertion. We wanted to find out the outcomes between using the PD insertion with an assistant surgeon and without an assistant using the freehand device. Next slide, please. And this laparoscopic technique was designed by me, so therefore I did all the procedures to make sure that there is no operator variability. 9 years ago, I designed this procedure and I trained surgeons to do this procedure. So therefore, there is no surgical technical variability in the surgeon's experience. We collected the data, what one would collect in these kind of procedures. And also, we looked at the time, what it takes, mainly time to set up the device and time to dock the device, which we will do in a robotic procedure. Because that is extremely important, that whether the time taken to start using the device is longer. And of course, we looked at the duration of surgery and time to undock, which is removing the device. We also looked at the impact of the device on the surgeon using the surgical task load index, which I'm sure many of you know, used by NASA and a lot of the areas where we can measure the impact on the surgeon. Next slide, please. So we totally performed about 75 patients, 25 on the control group, and then 50 on the freehand group. And there was no significant difference between the patient groups. As one would expect, these are high-risk patients with the ASA grade of 3 because of their renal failure alone, and of course with other comorbidities. And the BMI was not, it was average for patients of South London, which are a lot of people of Indian subcontinent. Next slide, please. When we looked at the times of the procedure, my staff were trained to use the device. And this is the time what it takes for us to set up the device once the patient is on the table. With the surgical assistant, it takes me 2.5 minutes to get everything ready. With the device, it just added 1 more minute. And the time to dock was 2.6 minutes. When I qualified with the surgical assistant, it was the time I can get the camera into position. And also the ease of use was significantly easier, and the time to perform the procedure was significantly lesser when I used this device, because I was giving instruction to myself. So I was preempting my plans. So therefore, we ended up in saving 18.2 hours of operating time with 46 hours of surgical registrar's time. So therefore, there was a very clear advantage that by using this device, I can perform the procedure a lot faster. Now in my unit, this has become a standard of care for this procedure. So now my colleagues are using this device with ease, as is other people in the country, in UK. So therefore, they're finding the same thing, that the learning curve was a lot easier. Next slide, please. And when we look at the impact of the surgical load index on the surgeons, as you could see, the yellow lines are how fatiguing it is in performing the procedure. And as you can see that it remains low in the first 5, where I chose easy cases. And then I was performing complex cases, as you could see with the yellow tall lines. And the orange dots are the lines, are the ones which are the lines which shows how fatiguing I was. So I was performing complex procedures, but I wasn't feeling tired. So therefore, it certainly doesn't impact in my ability, particularly with my well-being, in performing this procedure. Next slide, please. And also, when it comes to adoptability, one of our team did a study on how easy it is to adopt this device. So therefore, we did a study on prospectively on 20 surgical registrars to perform tasks not in the patient in a simulator with different exercises, and we set up 4 different exercises with increasing difficulties, and we looked at how they felt, how an observer felt about the ability, and also the head movement, number of head movements. And as you could see, they were getting better and better after the 3rd trial. These are registrars, which really means they've done equivalent to MS. And these guys were able to take the task significantly better by the 3rd attempt of doing the task. Next slide, please. And then when we looked at the overall head scope movements as well, on the left of it, exercise 1, you could see that there are more head movements to get control. And then by the 3rd one, the total number of head movements become lesser and lesser. So they become extremely adept to this technology. On the next slide, please. And the 4th exercise we gave was the complex exercise, where we combined everything, and they were able to achieve it with significant ease. So that means this device is easy to adopt, and people can learn to use this with a very short training period of time. And I think that is extremely important in enhancing minimal invasive surgery. Next slide, please. With regards to the type of procedures, what we can do, these are the early experience published by one of our colleagues. This published in 2018. These are the kind of procedures which are data has been collected, but majority of the procedures were radical prostatectomy, cholecystectomy, and lobectomy in the lungs. Next slide, please. A total of 105 procedures were done, and the surgeons who performed the procedure, this is a very crowded slide. I wanted to leave it there, but I'm going to summarize what the surgeons felt. The advantages was they felt that it was very steady. They didn't have to give instruction to somebody else. They can get on with the procedure, and they were able to do more and more. The disadvantages were what one would find in the learning curve. So if you look at the reports with the problems identified, it was all really in the early periods what they found difficult. So therefore, what we are developing is a tool to maximize that opportunity. Next slide, please. So therefore, I think the current status at the moment with freehand is we are performing increasing number of cases. It's launched in UK, Malaysia, and Caribbean islands. And I'm proud to say that we're launching it in India next week. And also, as the president identified, we are looking at using this device to enhance or fast track laparoscopic surgical training. So we are working with the Royal College of Surgeons to see how we can use this to enhance the training. Next slide, please. So therefore, the freehand device certainly, the camera holder device certainly helps us to do single surgeon laparoscopic surgery safely. The time gained of the surgical team member allows them to do other tasks, and also they can be trained efficiently. It is significantly cost effective in offering robot-assisted surgery, and we are planning to do a very larger cohort study to measure other factors as well. I just wanted to sort of briefly touch upon in the next slide my personal reflections of what I feel about this device. I think technology-assisted surgery is here to stay. I think we need to adopt these things. These are here to stay, and I think the solutions are getting accelerated in this time. So therefore, having a patient-centered approach, appropriate training, and a good case selection will help us to make the outcomes following minimal invasive surgery superior to open surgery. I'm going to be a bit cautious in making that statement, but I am going to make that statement because I think if we are careful with available technology, I think we can definitely achieve that. So President, Secretary, and everyone, to conclude, next slide, please. I feel that we are in an era of accelerated growth in healthcare technology. The healthcare industry has recognized this, and they are working with clinicians of interest to offer more accessible, adoptable, and effective solutions. We, the trained surgeons, and also the new generation of surgeons, need to embrace these solutions to enhance our patient care and deliver an efficient healthcare. I would just add one little warning. Next slide, please. Which is to say that there are a lot of technologies, but please do not let the device choose the procedure. We have to choose the device for the procedure. Therefore, that is the only word of caution I would say. And I would like to thank you all for the attention and for the kind invitation to share my thoughts. Thank you.
Thank you, Dr. Rajesh. In fact, it is something very exciting. I'm sure it is going to take the world of laparoscopy with a lot of changes, I'm sure, and it looks reasonably affordable as well. Because I'm not sure whether if I can, the next common question, what everybody think is, how easy is it to integrate into the existing system? And then is it commercially available, are going to be the immediate questions. Before that, let me quickly get into a few questions from the audience. Sir, how do you compare? Maybe again, it's a cost related question. Why Dr. Indra Raju Chinnaswamy is asking, sir, with the availability of qualified skilled assistant around you, how this transforms to improving the benefit of depending on a gadget based driven system rather than a human based assistance system. What is your thought process on this?
Yeah, that's a fantastic question, because that was the first question I had when they approached me. What do I need to learn as an assistant? Because it's nice to be standing next to a human whom I can talk to when I do the surgery. But actually, the reality is that that is one of the benefits of the device. But more importantly, we need expert doctors. I think we need doctors to do other tasks. In Britain, for example, we are in a crisis in needing more doctors. So we can't hide away from the fact that we can't be allowed to have senior trainees who can be learning other tasks standing next to me holding a camera. So therefore, it is inefficient use of their time. So in that way, certainly it helps us to use this device. And secondly, I think I'm sure we all had moments where our assistant is making us dizzy, giving us vertigo by the movements, what they do. So therefore, the stable vision helps us to do. And one final thing I would say is that I would want people to feel that this is a step into robotic surgery. By using this device, single arm control, where you control yourself, you are stepping into learning about robotic surgery, multi-arm robotic surgery, where you have 4 arms. So I see that in these 3 levels. So therefore, although I personally miss a person standing next to me having a conversation and do the surgery, in being efficient and effective, it certainly has a place.
Absolutely. Well said. President, sir, your comments, sir.
Yeah, congratulations, Rajesh. It is really exciting. And same time, I have a couple of questions to you. Why do you name it as Cobot? Instead of
it was registered as a robot. It's not named officially. It is collaborative bot. That's why it is. But officially, it is registered as a robot. So when whoever offers it out, they have to say it as a robot-assisted surgery. They can't call it as a cobot. I thought it's nice. It's collaborative robot.
Good name. Anyhow, it's good name. And if I buy the equipment from you, and how long it will take for me to get used to this equipment? That means, what is the learning curve? That is the time duration to get used to this.
That is an excellent question, an important question as well. So in the study, what we showed the trainees taking 3 to 4 sessions, trials with the device. For an expert surgeon like yourselves, I would say that 1 or 2 attempts outside the patient with the device, and then you will be able to do it. And we showed that when we launched the centers in Malaysia and Caribbean. So my colleague Tan Arulampulam, who's a laparoscopic surgeon, he didn't even go to the country. He was supervising them remotely because it is such a simple concept. We were able to support them to perform the procedure from UK. So it is significantly a shorter time to learn, and it is low risk as well because there is no complexity in the device which will make it challenging. So therefore, the simple concept of the device itself makes it less riskier. So overall, I would say that for an expert surgeon like yourself, it will take maybe 1 or 2 attempts to get comfortable with the control of the device, and then it'll be as normal. And I'm sure we can have a look when you come in to have a go next week.
And you said it is controlled by head movements, isn't it? head movement.
Yeah.
And then you have to turn your head like this and keep your head like this and looking at the laparoscopic screen. And you cannot turn this way, that way. Even if you make the small head movements, the field will vary, isn't it?
No, I think unfortunately the video wasn't very clear to you. Now it is a static control. So when you give an instruction, you make it live. The pedal in your foot makes it live. So once you get to a position, you take your foot off the pedal, like what we will do in a robotic surgery, the camera stays still. So you can move your head to make it, otherwise it will be such a tough act to do. So it is really when the pedal is live, the camera is live, it moves. Otherwise it doesn't move at all.
Excellent. I didn't notice that there is a control in the pedal, isn't it?
Yeah, exactly.
Um,
So very
and
similar to robotic surgery.
you said cost effective. How much
Yeah.
it costs? How much it
I mean,
costs?
obviously, the CEO of the company is flying in next week, so I don't want to say something. But all I can tell you is that it's in lakhs, not crores. That's all I can tell you. But it is significantly low. I mean, so therefore, I think it is going to make people offer robotic surgery in a smaller hospital than going to a big hospital. But because the reason I couldn't say more is he wanted to come and talk to experts like yourself and decide what is the correct cost for India. So therefore, I think, although I think when he comes here, he will engage with everyone and decide what is the appropriate cost. But all I can tell you is that it's definitely not a lot.
Not more than the entire laparoscopic system?
Definitely.
In India, our people are very smart and they make it very cost effective and they buy the entire laparoscopic system, selecting different methods and they make it very cost effective. Otherwise, in villages and periphery, it is very difficult. Only you said very smartly that it is in lakhs. If lakhs means up to 99.9999,000 also is lakhs, isn't it?
No, I mean, in UK it was the robot Da Vinci was 2.6 million pounds, and we got it for less than 50,000 pounds. So you can imagine the cost difference.
Okay, then
so that's the scale.
Then for Indian standard, you can't call it as cost effective. This thing only.
No, that's for
only for Vivek Bindal it is cost effective.
No, I think the price will be for Indian when he comes here.
Anyhow, it's a wonderful venture, Vivek. I wish you all the best for your launch. On 17th, I will be there, and 18th, I will be there, and I wish you all the best.
Thank you very much. Thank you.
Thank you.
I take this opportunity, Dr. Rajesh. Maybe you can permit few of the IAGS members to visit your center, the Center for Innovation, so that they understand the nuances of how much effort goes into release the gadget and how many regulatory permissions and sort of stuff. Maybe I'm sure there will be inquiries on the translational part of it before it comes to the patient use. Maybe we can write to the secretary, those who are interested, and with the due permissions, maybe you can allow few people at your convenience to visit your center as well.
Sure.
Thank you very much, Dr. Rajesh. It's been a pleasure watching and listening to you, and a lot of excitement. We look forward for handling this equipment in the near future. Thank you very much. I would request you to stay back with us for Dr. Vivek to complete his talk. I'm sure Dr. Vivek is a good friend of all of us. Dr. Vivek is a very young and dynamic technology innovator, I would say. He has adapted to the technology very fast, and in fact, he has 2 Da Vinci's installed and an array of other robotic systems installed in his center. And he's been instrumental in creating the false robotic program. In fact, That's the first ever kind of society, I'm sure, in this part of the world or globally rather, apart from the company as such, to give a advanced laparoscopic program, formal 3-day program and exam-based certification at the end of it was done very recently by this. And it's a very unique initiative taken by the IAGS out of the commercial programs. Right now, he's head of the department, Institute of Minimal Access Bariatric and Robotic Surgery. He's part of the Max Super Specialty Hospitals at Vaishali and Noida. He has had a very eminent career starting from his undergrads from the Maulana Azad Medical College and later on to the post-graduation. Then, no looking back, he had his FNB at the Gangaram Hospital, where he came out with flying colors, and then he had a subsequent training in fellowship in robotic GI and bariatric surgery at the University of Illinois at Chicago. Later, he was conferred the very prestigious International Scholar Award by the American College of Surgeons at the Washington, D.C. And he happens to have spent some time serving as a faculty member for the Duke University of the United States. And right now, he heads the Clinical Robotic Surgery Association of the Indian segment. He is right now the president of it. And he has been instrumental in bringing in the SSAT, the Society for Surgery of Alimentary Tract, to India. And for the India chapter, he right now serves as the president-elect for it. And to his credit, the CV runs to volumes, but then to come up two important things. And he serves as the sectional editor for our own journal, one of the very early start journal and high impact factor journal from the Indian Association of Gastrointestinal Endoscopic Surgeons, the Journal of Human Access Surgery. He serves as a sectional editor. And he also serves as in the editorial board of the SWAD, the Society of Obesity and Research. This research for diabetes. This is the SWAD journal by the ASMBS group. And he is also an associate editor of the Journal of Bariatric Surgery by the OSSI of India. Ladies and gentlemen, I have the honor of inviting my colleague and good friend, Dr. Vivek Bindal. In fact, we were amazed by the technological exposition shared by Dr. Rajesh. And here you can see now the surgical expertise using this technology. And he's here to share his experience. And he's going to tell us where this technology gives the edge on operating on the field of hernia surgery. Let us hear to the wisdom of Dr. Vivek. Ladies and gentlemen, Vivek Bindal, please.
Thank you so much, Professor Kanagwar, for those kind words. I am humbled and embarrassed actually to hear so much, and I'm very young guy in front of so many stalwarts here. Thank you, Professor Thangavelu sir and Dr. Mida and IAGS for giving me this opportunity to be a part of this August IAGS prime time, which we have been participating for the last 1.5 years, and it has been a wonderful initiative. My topic for today is robotic hernia surgery. What is the edge? I think we did 2 events last year on robotic hernia surgery, and it has been an area of our intense focus over the last 2 years. So Dr. Rajesh has given a very good perspective about robotics and technology. Now, many people say it's too expensive, it's too big, too dangerous. But the same things were said about automobiles and aeroplanes 100 years back. And we actually started robotic surgery in 2011. For initial 7 to 8 years, till 2018-19, there were a lot of questions, why do you need it? But now more and more people want to learn it, and the way systems are coming in, everyone has a lot of interest. I personally tried almost 6 different robotic systems, and let me tell you, every month there is a new system coming in the market, one or other, and we just saw about one. So just talking about the concept of robotic surgery, let us just look at not the Da Vinci system or CMR, what we have seen in the operating room. The concept is that the surgeon and the patient have been by the side of each other whenever you do open or laparoscopic surgery. Here in robotics, there is a digital interface through which the surgeon interacts with the patient. So whatever information is getting from the patient to the surgeon is through this interface, and it is augmented. That means the surgeon is getting 3D view. He can integrate the images, the CT, MR, as well as the Doppler images, and also the movement of the surgeon is translated by the robotic instrument inside the patient's body. So those movements are also through this digital interface, and that leads to reduction of tremor. That leads to fine scaling of motion. You can move your hand by 5 centimeters. The tip of the instrument will move just by 1 centimeter. Your left hand works as well as your right hand. So umpteen number of advantages, and this is the platform which is under progress, and each new system is bringing in something extra. And this is where the power of robotic surgery lies, in this digital interface. So this is one of the videos that we shot when our when our residents joined in Chicago, and we just told them to peel a grape using a laparoscopic scissors, and on the right side using the robotic scissors. They did not have experience in either of them, but here you can see in laparoscopic part the tremor is amplified. These are straight stick-like instruments. The margins are more ragged. While in the robotic system, you can see the same person without any experience is able to do a better job. So this is what the idea is. It's it's the technology is making you do a better job with the same skill set. So a lot of new things are coming up now. This is a Da Vinci XI system, which mostly we use in our hospital. I have been using SI earlier, and then we switched to XI as it came up. It has 5 ultra long arms which get docked to the patient's body. It has a laser targeting system, boom mounted arms, and there are a lot of instruments which help us do umpteen number of tasks, along with stapling devices and advanced energy. And there are simulators to help train surgeons. Now coming on to ventral hernias, or hernias per se, this is our case mix. Just a disclosure now, robotic AWR makes up almost 40% of our case volumes. It has been gradually increasing, and laparoscopic IPOM, open AWR, and laparoscopic AWR, all of these are in our armamentarium. We use them selectively, and I'll just talk about them, how do we use it. So this is talking about robotic TAPP for inguinal. This is how the pole position is. I keep my talk more video based, and TAPP inguinal is a good way to learn how to start robotic surgery. So that's why I'm showing you a video of a TAPP inguinal to start with. These are the 3 ports that we use, and we so this is using SI robotic system. This is a large right-sided indirect inguinal hernia. So what we do is we put in 3 ports. We have a camera which we are controlling, and I'm using a hook and a fenestrated bipolar. So you can see the pneumoperitoneum creating extra peritoneal space as soon as you incise the peritoneum. The degrees of motion of this robotic system helps us do a fine dissection, and 30-degree up and 30-degree down views help us work on the abdominal wall. So here we have reached the Cooper's ligament, and this is the sac area which we are going to dissect. I am reducing the entire sac, and then we put in the mesh here, which is being sutured with 3-point fixation. So again, suturing is an advantage with these robotic systems, wherein we are able to suture at difficult angles. Suturing on abdominal wall becomes different because there is no haptic feedback in these robots till now, most of them. Then you have to learn suturing not to break the suture. So one has to see how much tension is to be put in, and that is something which which you will kind of appreciate in these TAPP inguinals. These are good learning models. So using XI, this is a video doing the same procedure using XI system. So what we do is the large endoscopes hernia. So we put in the mesh and the switches early on. So we do not have to unlock. So we just use 3 ports. We do not use any assistant port. Put in the mesh and switches, park them on the side, and then we dock the robotic system. So this is one of the techniques we have developed to improve the efficiency. This is how the XI system is docked and the external picture how it looks like. Then we do the targeting of the camera, and this is the laser system to target. So using a force bipolar and a scissor in my right hand, I love both of these instruments. The force bipolar in the left gives us ability to work with a bipolar current and take care of any bleeding, while the scissors is a very versatile instrument, especially for dissection of hernias. So here I am raising a peritoneal slab. You can see to the large indirect hernia, we reduce the contents, and our first landmark is to reach the Cooper's ligament. You remain in the white. You basically look at the connective tissue, and here we see these are the this is the vas and these are the vessels. I have switched to the ICG view, and ICG view is going to help you decide the difference between the vascular structures and the non-vascular structures. Here the sac has been dissected off from the vas and the vessels. So ICG actually gives a lot of benefit in different surgeries, including hernia as well as bariatric or even gallbladder surgeries for cholangiography. This is how the sac is being ligated, and then we are going to divide the same. So these you can initially break sutures when you do robotic surgery because you will be unable to judge the tension. Again, looking at the ICG view to ensure that we are not dividing the vessels, and then we divide the sac. So ICG can look for the vascular structures as well as for the lymphatics and the biliary tree. So this is how you can see 30-degree up view. I am going inside the hernia sac, and you can see the testicle there. Then there is a small obturator hernia which you can see here, a fat plug actually, which we are taking down. So the ability of the robotic system to see and the stability of the system is very, very important. I think, as Dr. Rajesh was also mentioning, stability of this laparoscopic arm or the camera arm or the endoscope arm is very important, and that is what provides us a lot of advantage. Mostly we do not clean the camera even once during the entire procedure, even if it is 2 to 3 hours. So here we are suturing the mesh to the Cooper, as well as we'll suture it up there, and suturing becomes an easy job with the robotic system. Here we have sutured it laterally as well, and then we close the peritoneal flap. So this completes a TAPP with an XI system, and then we undock. So why abdominal wall reconstruction? AWR is another procedure which we do for all these complex hernias. This is a post-open polycystectomy hernia, and this is a post-open midline laparotomy hernia. So you can see paramedian laparotomy. These kind of hernias are not served well by IPOM, which we used to do, and we basically do a component separation after visualizes hernia reconstruction, and the aim is to do a midline reconstruction and the mesh reinforcement of visceral sac with a large mesh. I think the ETAP and ETAP-RS, ETAP-RS star techniques have provided us with wonderful results. And the idea is that we are putting the mesh not intraperitoneal because that can lead to lesions, not subcutaneous because there is no right space and there's a lot of chance of infection, but in between the rectus muscle and the posterior rectus sheath, which is the sublay position, which is the best position for putting in the mesh. This technique was described by Igor Belyansky and group in year 2018, published in Surgical Endoscopy, and Igor has been at the forefront of developing robotic abdominal wall reconstruction. We started it the same year in 2018, and this is our publication. This was the first one from India on robotic ETAP in 2020. So we have done now almost close to 80 robotic abdominal wall reconstruction procedures. And these are some of the results. So this was initially when we used to do laparoscopy. This patient had open cholecystectomy, then a mid-line laparotomy, room by hepatogenostomy, and then she had a large incisional hernia which was getting obstructed. We did a laparoscopic bilateral hepatard, a very challenging case because of multiple previous operations, but it was done well, and you can see the good cosmetic result. Then we started doing robotic. This was one of our initial cases. This lady had a post-appendectomy hernia laterally, and these lateral boundary hernias are not served well by laparoscopy, by IPOM. Here we have done a unilateral edaptar. So we have divided the transversus abdominis, and you can see the good cosmetic result after a few months. Now this is incisional hernia. Incisional hernia post multiple laparotomies. I think 3 times she had undergone surgery, and this lady had a large bulge with divarication, and she had obstruction. You can see here. Now we did an inferior crossover and transversus abdominis release using the robotic system. And after a few days, you can see just 4 punctures and how well the outcomes are. Then recurrent hernias. This lady had an IPOM, post appendectomy, large 20 by 25 centimeter mesh. We did a robotic edaptar, and now you can see how good is the result. So coming on to MIS, as we all know, if open procedure can be replicated in a minimally invasive environment, then there is no argument against MIS. MIS is comfort to patient, while open EWR is comfort to surgeons. So this is how we place the patient. That's coming down to the steps of the robotic surgery. I'll show 1 or 2 videos. This is how the patient is positioned on the table. This is the theater, how it looks like, because we need to have ergonomic screens, movable platforms, and for initial port placement, this is the theater setup, and this is a picture of the old SI platform which has been docked, and the theater setup with a robotic procedure. So we know these are complex exercises, long procedures. This is a video showing transversus abdominis release, which I am doing, and you can see this is a OT video, and it is going to show you how robotic surgery helps us. An inferior crossover has been done, which is in laparoscopy. It is an ergonomically challenging way to do, but here the dissection, the rhizodesis, and the long procedures can be done with comfort to the surgeon. You can see the assistant is also sitting by the side. The surgeon is sitting on the console, while the robotic system is taking the brunt of all the ergonomics, which otherwise would have been on the laparoscopic surgeons. So this is one of the patients whose video I'll show. This lady had a open appendectomy followed by large hernia, for which IPOM was done, and here you can see disruption of linea semilunaris. The entire linea is gone. One of the boundaries of hernia is made by this iliac crest. So we planned a robotic edaptar. This is the hernia side, and we basically would enter from the left retrorectus space. So we typically do an optical entry. You can see we are going in between the rectus muscle and the posterior rectus sheath, and then we are going to put in the second retrocards. We would prevent any kind of injury to the neurovascular bundles at this point in time, and we are going to introduce the Da Vinci cannulas. So this is a very limited space, and it's a potential space. So to work here, we have docked the robotic system for the superior crossover. It's being a limited space, it becomes difficult to work around in these spaces. But here you can see the robotic scissor, how well it can move, and it is dividing the posterior rectus sheath to expose the falciform ligament. You can see the angulation, the degrees of freedom of the robotic instrument. also the stability of the platform. So here I have exposed the linear elbow, and we need to see the opposite rectus sheet, opposite posterior rectus sheet. So this is the opposite posterior rectus sheet. I typically open up PRS a lot, try not to open the peritoneum, and here I am opening up the opposite posterior rectus sheet. So here the degrees of freedom allow you to perform a very precise task. This, yeah, so here we do not want to make a hole in the linear elbow, which which is going to cause a lot of problem. So a secondary trocar is being placed here, and then we are going to change the docking so that we can go downwards in the area of the hernia. So the docking is changed. The robotic trocars have a remote center, so there is no torque on the abdominal wall, and that leads to reduced pain as well as reduced hernia rates, the trocar site hernia rates. So here we are saving the peritoneum. What robotic surgery provides us is we are able to save a lot of peritoneum, more than what we are able to do in laparoscopy, and that has prevented the need of a transversus abdominis release in many of our AWR procedures. While if we do it laparoscopic, we have to do a TAR. Here we have reached the area of the sac, and there are dense ball adhesions because of the previous IPOM mesh which has been placed. There are attached. So what we typically do is, this is a lateral hernia, I go laterally also, and I'll tackle it from medial and then go to the hernia side. So to enable us to go lateral, I am doing a transversus abdominis release starting from top down. Here you can see the fleshy muscle of transversus abdominis being divided. Now you can see how the robotic scissor is turning itself so that one is able to divide the T in a very precise way without injuring the peritoneum, without doing any buttonholes, and taking care of the neurovascular bundles. Again, you can switch to ICG here to check for the neurovascular bundles and its integrity before you divide the TA. As you go down, the transversus abdominis becomes aponeurotic. Now, as we do a part of TAR and we lateralize, we go laterally, and we basically try not to make any kind of buttonholes, try to keep transverse fascia down, and you can see we have been able to do that here, reaching all the way laterally where the area of pre-peritoneal fat comes. You can see the tack, the previous tack is seen of the previous mesh. So all these post-IPOM hernias, we have been doing them very quite often now, and another tack is there. They're all difficult cases. The anatomy is all distorted, but one needs to recreate the anatomy by going from the vertical area to the scarred area, and then gradually working around things to recreate the anatomy. So this is the IPOM mesh. Again, another tack you can see here. We typically go above the IPOM mesh and dissect it off from the rectus muscle. So here we are going down, and this is dissecting it from the iliac crest, and then we go all the way lateral. So once the dissection is done, the pubis, the Coopers, and the lateral boundaries exposed, then we suture. Again, suturing is a big advantage. Here we are suturing the PRS peritoneum complex. So once this is suture closed, we need to suture close the anterior defect. Before that, we excise the sac so that there is no seroma. So this is excision of the sac, and then we suture. It's a huge defect. You can see. So again, suturing of these huge defects is very difficult. I'm using 3 V-lock sutures from 3 different edges. So this is the second V-lock suture. The first one is down here, and this is the third one. So bringing in all 3 V-lock sutures together in the midline helps us enable close even these large defects, which otherwise would be almost impossible to close. And the robotic system helps us suture on abdominal wall in a very efficient way. So this is how the defects are closed, and Then we remove the needles and then we'll have to put in a large mesh. So this is a heavyweight polypropylene 30 by 30 centimeters, which is being placed. This lady has been doing very well. This is almost 1.5 years before that we did the operation, and she has been under continuous follow-up without any kind of problems. So I think these kind of procedures are very difficult to be done by laparoscopy, and robotic technology definitely helped us do this in a better way. Then this is inferior crossover. If time allows, I just go through this. This is a open laparotomy hernia. So the earlier one was superior crossover. Here there are multiple Swiss defects in the supraumbilical area up to the Ziffy sternum. So we do an inferior crossover. Again, optical entry into left retractor space. Then this is the first port, is the second suprapubic port, and then we put in 2 extra Da Vinci cannulas for the robotic system. So this is how the port position looks like, and the robotic system has been docked to 2 ports have been placed on each side, and then we are exposing the rectus muscle, the postural tissue on both the sides. So here we are dividing the medial edge of the postural sheet, going all the way up, and this is the linea alba and the defects. So multiple Swiss defects, we are going to deal with them and reduce all the contents as we go up all the way up to the Ziffy sternum. So the benefit of this abdominal wall reconstruction is you reconstruct the entire wall from Ziffy to pubis, and all these incisional hernias are dealt with very well. You can see multiple defects, small and large. You can see the previous sutures. These are the smaller defects, and then we reach all the way to the Ziffy sternum. Then to enable postural closure, we have to do a transversus abdominis release. So here I am dividing the TA. You can see how well you can see the transversus abdominis, and then we are lateralizing the peritoneum. After the TAR is done, then we suture close the posterior PRS complex, and then we suture the anterior defects. So again, as in the last case, the suturing is made easier by the robotic platform. Inferior crossovers have a very difficult ergonomic position for the surgeon because he has to stand in between the legs, and the instruments strike the thighs. So it's very difficult for a surgeon to perform all this suturing on the entire abdominal wall with inferior crossovers. And we have switched more and more to robotic system for all these inferior crossovers. And then again, we put in a large mesh which we suture fix to the Ziffy sternum. And again, this is after undocking, and the lady is doing well. Again, more than a year down. So another video, I'll not go into these details. Another video, I'll just skip it. So the idea is, primum non-nostril surgery should be done to bring benefit to patient and not glory to the surgeon. In summary, open hybrid laparoscopic robotic techniques have roles to play in different patients. The learning curve of AWR is steep, and understanding of anatomy and advanced MIS skills is important. Robotic surgery is here to stay in hernia, especially in complex ventrals and AWR. And I would encourage every surgeon who has a long career to get trained in robotic surgery and take the advantage. I shall be glad to answer any queries right now, or else these are my contact details, and I can be contacted upon in these mobile number and email. Thank you so much, IAGS, and thank you, President Sir and Dr. Pinagawal, for giving me this opportunity.
Thank you, Dr. Vivek. In fact, it looks very mind-blowing, like so many difficult steps. It looks they're very systemized due to your SOP-based approach, stepwise, and we can see the comfort of suturing. That is always a challenge when we do PRS and the inverse surgeries, and it looks like you're doing as from at your comfort level. Thank you very much, Dr. Vivek. I'm sure robotic is here to stay. People may claim various thoughts, but it has very clear indications. See, I don't propose someone to do a robotic tap or TP, but then if somebody wants to do something, these type of specific procedures, which otherwise may be a real challenge, already we are doing a rectification process and we should not end up more damage. That makes robotic very plausible. I would like to take comments from the president and then move on to Dr. Rajesh, because I'm sure he also has a share of thoughts. President, sir, over to you, sir.
Vivek, it was a excellent presentation, wonderful videos. I like to congratulate you for this presentation, Vivek. And you select patients for robotic surgery in hernia, or you do all your hernia surgeries in robot?
So we do select because there is a financial cost involved, and insurance is now reimbursing for robotic surgery. Many of them, but not all. So many patients would not be able to pay. So we do the same procedure as laparoscopic also, and we would definitely, in some complex cases, insist that robotic is going to be better. We tell the patients, and many times they would also agree. But as you know, there is a cost difference, so ultimately the financial will also come into play.
No, my question is slightly different. I just want to know, if cost is not a factor, then you will do all your surgery in robotic, or if you can do it in laparoscopically, will you do it that way, or use robotic?
If cost is not a factor, all surgeries would be robotics. No doubt, it gives a lot of comfort, especially in AWR procedures. It is something. It is totally unparalleled. And I've done more than 200 AWR laparoscopic and less numbers robotic, but I'm way more comfortable in robotic as compared to laparoscopy. And I would say any surgeon would be who is past the learning curve of robotic surgery. The stability of the platform is so much. The ability to control all the forearms yourself, the ability to dissect on the abdominal wall by turning the camera upside down by the 7 degrees of freedom, the ability to save the peritoneum. I think it scores over laparoscopies for these specific procedures. For AWR, hands down, it is better than laparoscopy.
But you shown some videos in the beginning that tap and surgeries, which I thought can be easily done in simple laparoscopic procedure.
Yes, sir. Absolutely. TAPP can be easily done laparoscopic, and we do most 90%, 95% of our TAPPs are laparoscopic only. Now, this is a good training tool. So why I wanted, because many people do not do it at start. So I wanted to show a simple video which people are doing routinely, and they are able to understand how the body system would help. One has to learn how much loss of haptic feedback. What does it mean to them? They can break sutures. How controlling the camera is different. I've seen robotic surgeons initially in the learning curve blaming their assistant to hold the camera properly, and then their assistants telling them you are only holding your camera. So it takes some time for those. I see TAPP as a very good procedure. In fact, better than even cholecystectomy for a person to start with, because in gallbladder you can injure the CVT, but in TAPP it's difficult to injure it. You can always injure, but I think it's a safe procedure to learn.
We are all, we are not me. I'm a very old timer, and I used to let my assistant for my mistake also that you are not holding the camera properly. That's why I'm not able to do it.
This
So that's not possible in Rajesh robot your robot. It's not possible. Anyhow, so how cost effective? How much? If say in minimal invasive surgery for a tap or tip or other complex procedures, it costs say 1 lakh. How much it will cost in your robot?
So it would depend on the hospital system. So now in our hospital system, basically, if we do a laparoscopic IPOM, we use a mesh and a tacker, which is to the tune of 60,000. And if we use the robot, we do an AWR in which the mesh and everything is 10,000. So we save 50,000 there, but the patient has to pay 1,35,000 extra for the robotic system. So overall, there is a difference of around 75,000, which the patient has to pay. Mostly now, the good news is that robot is being covered by insurance, and all private insurances for complex hernias would typically cover the robotic system. We have been able to get a lot of insurance coverage for our patients. Government insurance companies are still something we need to crack, and I think with newer companies coming in, it was going to happen over a period of time.
It was a nice presentation, Vivek.
Thank you, sir. Thank you so much.
Thank you very much, President. Dr. Rajesh, before I allow you to comment on Dr. Vivek Bindal's talk, there have been a couple of questions which have come after Dr. Vivek started speaking. Dr. KMS Kapadia is a fellow of the English College and the Edinburgh College. He asked you how easy is to hand over the camera to an assistant if the transition time, if there is a failure of this robotic control or robotic control, I would say in your words. And then he also wants to know, do we end up having multiple pedals for energy devices and these things, or like a clutch, the foot pedal can be used for both camera control as well as the energy device control? These are the quick questions I would request you to answer, then move on to Dr. Vivek's talk.
Sure. I think to start with the second question, I think it's important to remember that it's separate pedal, so you will have a diathermy pedal if you need to. It's important that you get comfortable with the pedals, because if you're going to, as I was saying earlier, this is in a way a step up to a robotic training. In robot, you've got 4 pedals. I mean, Vivek will tell you. So therefore, I think it is really being aware of it. There's another device which was in the market where they had the hand control. So you have a sensor in your finger where you move the finger, camera follows. And that had difficulty. People had difficulty in controlling it. So therefore, it is really something a person need to get used to. With regards to getting used to the time of it, that is what the paper showed, that with 3 practices, people are able to get control of that ability to move the fit between 2 devices. So it doesn't seem to be difficult, but this question is absolutely right, that it is something one need to be aware of in doing it. With regards to what happens if something emergency happens, is really you just unhook it from the robot. So it just takes about maybe 3 to 4 seconds. I had few cases where there was a problem. My colleague was doing it. You unhook it, the whole screen is in your hand, whole camera is in your hand. So therefore, you don't need to take a lot of time. We are talking seconds here, and there's a problem. Yeah.
And the other question is, sir, are we having plans to improvise these 2 additional arms? Like for instance, it looks like the gesture control seems to work very well for the camera. Does it mean these type of things can be added as an additional arm to the surgeon to retract or to do some specific maneuvers, or autonomous hand? I'm not sure what the person asked for, but he goes on to say, can we have 3 or 4 separate autonomous robotic hands? That's what I understand the question he tries to ask you. What is your take on this?
And I think there is definitely some technologies available. I think it's not fully in practice at the moment. There are prototypes for the soft arms are in development at the moment, soft robotic arms. I think the question we have to ask ourselves is, what are we trying to use this robot for? I mean, Vivek's work is commendable. I mean, he's doing cases people don't want to do. He's doing a amazing work, I should say, with robotics. So therefore, I think we have to be very careful in using this technology for the procedure, because sometimes the robot can be the most dangerous instrument on the operating table if the patient is not the right patient or the procedure is not the right procedure. So I think with regards to using multiple arms of the free hand, which means there will be 3 people with sensor in the forehead controlling it. Now, when we designed this, the aim was to keep it simple so that it can be used for certain types of procedures, not to replace a robot, not to replace a Da Vinci. This will have a place for certain types of procedures. So Da Vinci will have complex procedures such as what Vivek is doing. So therefore, I think it is an addition to a robotic armamentarium for a team, for a hospital, rather than having 3 or 4 of the free hand. One other thing I would add, I think we were talking with Dr. Sangu the other day about voice control as well. Whether we can have a voice control. People tried that and it became a bit of a challenge. So I think often what we want to do in operating room is the technology has to be simple so that everybody in operating understands it and stops when something goes wrong. Not having the most complex system. And that is one of the things I think Vivek rightly alluded to. The learning curve with Da Vinci is not that simple. So therefore, it has to be careful. But at the same time, with the right approach to these things, having the patient selection, type of the robot, what you want to have, that will be the best way to match these things rather than one robot for all procedures.
Rajesh, do you think that this head control is better than voice control?
The team which tried that in US, I think they were from, I can't remember where. I think the issue is that you have to have a mic which works very well. And I mean, I don't want to take too much of time. So we are developing a operating microscope, which is very small, and we are doing voice control with that one. So to zoom in and zoom out, the latency is a problem. So when you say it, it connects and it works. It takes time. You're looking at 0.8 to 1 second, 2 seconds at times with the voice control. So with the technology is not there at the moment. So the pedal is much more mechanically driven, so it's a lot simpler. But I'm sure at some point there will be voice control will be better, yeah. I think, yeah, but not presently. Yeah.
In the course of your discussion, you mentioned about ultrasound cordless probe, and you can use mobile phone as ultrasound screen, some apps you can download and you can do it. Can you explain a little bit on that?
Yeah, I mean, I'll show you the probe next week, but if people can see, this is my ultrasound machine. So when I scan the patient, I get the images, and when my registrar scans the patient, I can look at it from home. And the cost of this ultrasound machine is, I think it's about 60% less than a fully fledged ultrasound machine. So therefore, I think there are 2 or 3 products at the moment in the market. GE is releasing one 6 months ago, and we've done this a few years ago. So therefore, I think the way I see the healthcare is going to be in the next 5 years is that patient, by the time they come to an accident and emergency, we will know a lot more about them before they come to the hospital. I think the patch I was telling you about, they put them on the carotid. I can have their hemoglobin, creatinine, lactate at the moment, even before they left home. So I can decide. So therefore, I think that a lot of these things are really makes the care go to the patient at home, start the care at home, and then they come to the hospital. So things continue rather than starting the care in the hospital. But I'll show you next week. Yeah, definitely. Yeah.
Right. Thank you so much, sir.
Dr. Vivek, I'm sure you have questions to Dr. Rajesh.
Yeah, no, I think that's a very interesting technology shown by Dr. Rajesh, and Dr. Deshpande in IAGS, all of us know, started with the voice controlled camera. I think that was too early for its time. So now this is the right time for any kind of robotic technology or automated technology to come in. Are you planning to add some more arms there, as in this is just one arm? Can you have, like, it is just easily attachable to the table? Do you conceptualize or visualize 2 more arms attached which can work as operating arms, as is shown in some flex decks or some articulated instruments?
Yeah. I mean, definitely it can be. So as long as it's a fixed positioning, so for retraction, it can definitely be there. I think if there is a liver retractors or something you want it to be held with such small movements, definitely it's possible. Now we are starting to try that, having gone through the low risk cases. But at the moment, for the top point of view, I wouldn't say that I would recommend to anybody to start with, but it is something definitely worth considering, if somebody wants to do it. And just from the cost point of view, I would add that a lot of the companies, mainly Intuitive, their costing model has significantly changed since COVID. So now the costing model is very different to what they used to do before. So even from the primary capital cost point of view, it's very different now in buying a robot or getting a robot. You don't even need to buy them. They loan the robots now. So therefore, I think the costing is significantly changing, and the landscape of other robots coming in will make the cost of robotic surgery lesser, I would say.
Right. And what is your take on the articulated instruments? Because I have been trying them for last almost now 9-10 years in various forms. Somehow they always look very cumbersome to use. Do you see, and all of them have been trying to replicate what Intuitive or Da Vinci system has been able to do with the master controllers. So do you see any instrument which holds promise in particular in these articulation kind of stuff?
I mean, it's a very smart question actually, because that never really took off because it's too complex. It's too complex, and it just makes it so difficult. And in the whole setup, this is what we were talking about technology. Sometimes people put everything into one package, thinking that will solve all the problems instead of solving one or two problems. And I think that is why, I tried those devices, and it becomes challenging to get them orienting and very bulky as well they are. I know that there is a technology which is just being tested in Stanford without any touch. So it's completely virtual. So you have a virtual gloves and you can control the device which are actually touching it. But that may be about 2 or 3 years away, where you don't need to touch the device at all. You dock it and then you move your hands away, then you move in air and the whole thing will move. So, but that is about 2 or 3 years away. Yeah.
All right. I think with this combination of technologies, some robotic arm and some articulated instruments and 3D laparoscopy and ICG together, we can possibly have a lot of advantages of robotics without getting the actual robo and just getting, as Dr. Thangavilu was putting it, making it cost effective by having one Chinese LED generator and one screen of Samsung and one camera generator of 1288. So you have multiple different things together, one cobot and one articulated instrument and one 3D laparoscopy, and you have a robot in your theater.
He said it right. We need to challenge these companies to make them work for us, not the other way around. Until now, Intuitive had that monopoly, so we have to work around them. But I think the time is done. Now it's the user time, in the sense of it's our time to challenge them to work for us in every way possible. Yeah.
Absolutely.
Thank you very much, gentlemen. I wish all of us wear a 7.5 or 8 size sensor glove and we are up and ready for the surgery. So it sounds very exciting, and I'm sure this will evoke definitely a lot of spark from the youngsters to take up this field as a exclusive field. I wish the biomedical and the biotech team takes a cue on this research, so that it gives a very clear direction how the world of instruments are going to be in the coming decade. Ladies and gentlemen, it's been 90 minutes of a lot of intensive learning. I thank all of you for joining us this evening. Now I invite our National Honorary Secretary, Dr. Satish Meeda, sir, to give the final comments and the formal vote of thanks. Over to Meeda, sir.
So it has been really a fascinating session. And we know that there was a revolution in surgery when laparoscopy came more than 3 decades ago. And I think robot is really, as we see, is going to bring the next revolution. It has come to stay, and we know there are some factors, especially in India, especially the cost factor. But I think with more and more innovations, people like Rajesh who are doing original research work, we'll be able to provide initial instruments to many smaller setups. And when laparoscopy came, the advantages were passed on to the patients. Means surgeons had to struggle, but this robot is going to bring a lot of ease, not only to the patients, but to the surgeons also. So Dr. Tangavelu, you can start it. And at this age, I think uh, there'll be no tremors and you can perform many more complex surgeries. And we look forward, like pioneers like you, to take up who took up laparoscopy, will also take up robotic surgery. And we also look forward, because when I just completed my uh, master's in surgery, laparoscopy was just peeping in. And we also had resistance. We were one of the pioneers to start in our region. There was a lot of resistance. And so I think robot will not have that resistance, but it has come to stay. And really, some of the fantastic surgeries are being performed. And we look for more collaborations with Dr. Rajesh and other innovators as an association also. So that this technology, learning, and all this can be passed to the newer generations. So I thank you both, Dr. Rajesh and Dr. Vivek, for sparing their valuable time and sharing the knowledge with us and all the delegates who have participated in this session. And the recordings of this session will also be available in the Facebook and YouTube. And those who could not watch it, they'll have the pleasure of it watching when at their leisure time. And we can also relearn the things we want to learn. And I thank the Doc Plus team for supporting us in the IAGS Prime Time, which is very popular session now. And I also thank our President, Dr. Tangavelu, and the coordinator for this, Dr. Kanagvel, for arranging this show. And hope next fortnight we'll come up with another new topics. Thank you very much. Good night. And we'll be sending the certificates to both of you by mail.
And, thank you very much, Mida sir. Thank you for all the faculty. With the permission of the President, I will tell a brief info about the subsequent program. Ladies and gentlemen, the President has coordinated a brilliant program with the European Hepatobiliary Pancreatic Association on bile ducts injuries. So we will be soon releasing the information about that. The president of the EHPBA is going to address on this specific issue with all the galaxy of Indian experts. Thank you very much. And we wish you good night and stay safe. We look forward to meet you very soon in our next program of the IAGS Prime. Good night, everyone.
Good night.
Thank you, Doc Plexus.
Goodbye.